Well, thanks very much, and thanks everyone for coming to this webinar. And I'm really thrilled to be the first speaker. It's really exciting. As you've just heard, I'm a clinician. I was a GP for many years, although I no longer see patients. Full-time academic, and I would say I've been pretty agnostic about technologies. I'm not one of these enthusiasts. I'm quite old-fashioned in some ways, but I'm not anti-technology either. So I'm going to tell you about the remote by default study, acknowledging our funder, which you can see on the slide, Rebecca Payne, who's here, and many, many other people. This was a huge team effort. I've got to work out how to click it. Okay, so here's a summary of what we did. We followed 12 general practices across the UK, big ones, small ones, urban ones, rural ones, digitally advanced practices, and digitally very basic practices where not even the telephone worked. And I think one of the strengths of this study was the diversity of practices who became our partners in this 28-month ethnography, where we built relationships with the practices. We went back, we visited, we did 500 hours of ethnography. We interviewed nearly 200 people. So it was fun. It was one of the most fun studies I've ever been involved in, actually. And what we produced was longitudinal case studies of the introduction of new technologies, the adaptation of those technologies, the routinization of those technologies, where they stop being new and become part of the new normal going forward. And also, we studied the abandonment of technologies. And I think that's quite important, how people introduce technologies, and then when they don't work, they kind of roll it back and go back to how they were before. And I've been studying innovation for a very long time, and I know that one of the big gaps in the literature is the study of abandonment, because people are much more likely to write something up if it's not abandoned. We also did lead interviews with policymakers, with industry, patient advocacy groups, a lot of other groups as well. And we built relationships with those national policymakers in particular to raise their awareness of what was going on, but also so that they were hungry for the results. And they are now sending me emails saying, come on, what have you found? Which is nice. And to ascertain policy priorities. And so what we've got now is an engaged network of senior stakeholders for our dissemination phase. And then we did workshops, rather like this one, but a bit more, lots of interactive virtual breakout groups on particular topics. Four in particular. One was on access. We're all into universal healthcare. We all know that digitalization can sometimes exclude vulnerable people. So access, triage links very much with issues of equity. And I'm particularly interested in people who are multiply disadvantaged. We had a workshop on quality and safety, another one on workforce and training. And we all know there's a workforce crisis in healthcare around the world. And then we had one a bit more geeky on technologies and infrastructure. And each of those workshops led to focused follow-up activities with different stakeholders, including policymakers and patients and all the rest of it. So it was a complex study. And I'm not going to tell you all the findings, you'll be glad to hear. But the first theme I want to pick up is patient safety. And this was something that Rebecca led on. So she's here, and she'll probably be taking the questions on this, but just to rattle through some findings on safety. I think you'll be quite interested in this, because in following 12 GP practices for more than 2 years, talking to staff and patients, we never identified any safety issues. We didn't identify any never events. We didn't even identify what we call near-miss events. So we changed our research question, really. In relation to safety, we started looking at how GP practices avoid safety incidents when they're providing remote care. And most remote care was by telephone. You know, it wasn't video. It was fairly low tech. And we also looked beyond our 12 practices to hunt for safety incidents. And we looked at, for example, indemnity claims where someone had complained and legally gone through the litigation. We looked at complaints. We looked at cases that were used for training. And over a period of many years across the whole of the UK, we identified 95 such incidents. I'm sure there were more, but we found it pretty difficult to get hold of any. And I think that's quite important. So how did practices avoid safety incidents? These are some of many reasons, and I'm only going to give you a quick skim across this. The first thing is that both clinical and reception staff tend to err on the side of caution. If someone's phoning up about a sick baby, we all know you say, bring the kid in. You know, there's no way you'd say, oh, well, let's leave it because it's probably going to be all right. In general, staff in general practice are well supported. They feel safe passing problems up the line. They can ask their line manager, a junior doctor, say, can ask a senior doctor, etc. GP practices tend to know their vulnerable patients. Not all of them, but most of them. Many vulnerable patients are known personally to practice staff. We looked at the sort of technical arrangements for preventing safety incidents. And there's a lot of ways in which, for example, the duty doctor callback list is used very flexibly and adaptively. People can add patients, they can move them up the list, they can stick a post-it note on someone's screen saying, can you call this lady back quickly? And the one I like best is staff break the rules. Staff are really creative. They invent things. They invent little, particularly paper solutions. They look like a little book that they write things in. And those solutions, which are developed from the ground up, then become formalized. And the practice kind of they turn it into a standard operating procedure. But initially, these are things that the staff shouldn't be doing if you look at their job descriptions, and then they get formalized. So we looked at those kind of processes, and these were some of the ways that safety incidents were prevented. But there were some areas that we fed back to practices which we thought they could improve on. They were doing really well, by the way, but we thought they could improve. The first is the telephone being used optimally? If you are phoning a patient, are you listening closely enough? Are you building rapport? Are you probing? Are you thinking this particular patient may not have enough privacy to disclose the things that I need to hear about, type thing? And we think there's a big area of training around how to use the telephone. Everyone goes on a course to do video consultations. I've never been on a course on how to use the telephone. Secondly, many practice workflows are still designed around a default of patients walking into the surgery. There are waiting rooms. There are we haven't quite improved all the workflows to incorporate the fact that most people now are contacting the practice remotely. So there's a bit of work to be done there. Questions about vulnerable patients who haven't yet been identified. Are we looking for them? And are we making adaptations for all of the autistic patient, for example, who doesn't look as if they're any different from anyone else? You know, if you've got an elderly person on a walking frame, it's clear that they're old. If you've got somebody in an ethnic dress who clearly doesn't speak English, it's very obvious they need support. There's some conditions, obviously, that are not so obvious. Remote working is stressful. Are we supporting and training our staff optimally? The answer in UK is not yet. Are interruptions minimized in busy reception areas? Some of the incidents that we did discover was when someone was interrupted partway through a task and then they just forgot about it. And then are all staff aware of key clinical conditions and trajectories? The patient who continues to deteriorate, for example, some of these things are unsuitable for remote, and I bet a lot of people listening will be able to give me a list of things saying in our practice these would never be handled remotely. But is everyone aware of those? So those are some of the ways that we can improve even further. There's more information here. This is Rebecca's paper on patient safety, published in BMJ Quality and Safety. We've got patient leaflets and resources. And actually, we've also got a list of competencies which we developed for staff, which I think I'm going to tell you about in the next but one talk or section of my talk. So let's look briefly now at the second theme that I'm going to tell you about: access, triage, and equity, crediting to one PhD student, one postdoc, Francesca and Sarah, and they've done some great work here, which I'm now going to try and present on their behalf. Now, what they showed, or what we showed, was that it's really getting much harder to go and to see a doctor or another clinician. The patients have to, first of all, find the services, perhaps find them online. They have to explain their symptoms. They have to categorize and classify their symptoms. So point to the part of the body where it's going wrong, that kind of thing, which for most of us is pretty straightforward. But for example, I've got a brother with learning difficulties who finds this really problematic. They also have to negotiate with the front desk staff. Now, some of you will know the expression, technologies configure the user. This is from Steve Woolgar. And what he means by that is that any technology includes assumptions about who is going to use it and how. So those modern telephone systems assume that the patient can hear, and they assume that they can kind of keep up with the instructions and press the right button at the right time. And I'm sure we all know people, perhaps our own relatives, who just can't use the phone anymore because it's been configured for a different kind of user. Francesca developed this concept of the digital facsimile. Many decisions in general practice now are made on the basis of looking at what's on the record and looking at perhaps an email, perhaps a set of messages, perhaps a picture of a body with where someone's clicked on a particular part. And she called this the digital facsimile. So the patient has to create an accurate and persuasive digital facsimile. They've got to convey, for example, that they've had severe pain in the lower abdomen for 3 days and it's not getting better. And some patients can do that and others can't. And the ones who can't have usually got a combination of low digital literacy, low health literacy, and low system literacy. They simply can't get their head around what is going on in the system. How do I need to navigate this? Now, staff in general practice tend to now use the digital representation of the patient to determine their eligibility for care and to allocate a particular kind of appointment, either a telephone call back or come in. Safe triage, therefore, depends on the accuracy and the level of detail and the persuasiveness of that digital facsimile. Now, we found that staff in general practice are actually pretty good at filling in the gap. So they'll have a look at whatever the patient has written or conveyed, and they'll realize that this patient isn't very good at conveying what's wrong with them. And staff can often fill in the gaps by searching elsewhere in the record. But actually, that depends on the staff member. It depends on how well they know the patient. And you can see that this could become quite risky. Another thing we found, and particularly Sarah Rybczynska-Bunt's work, found that if the patient had a bad experience at what we call the digital front door, that then influenced their ongoing engagement with the healthcare system. And it wasn't all that uncommon for a patient to have had 2 or 3 situations where they just couldn't get through, and so they gave up. And they as far as they were concerned, the general practice was now closed and inaccessible to them. And some patients actually said, no, my GP practice is closed now. It's been closed since the end of the pandemic. And what they mean is closed to me. Here are 2 papers One's led by Francesca, one's led by Sarah. Those of you who are interested in the social science aspects of remote care, one's in social science and medicine, one's in sociology of health and illness. So those are quite theoretically deep, but if you're interested in theories of digital access and equity, these papers, you might be interested in these. Now, thirdly, education and training. And the whole workforce issue. Actually, I've put me, because I led on the training paper, but Francesca again led on some of the workforce stuff. What do we find? This stuff is pretty unsurprising, but it's also pretty important. We found really high workloads, and that's partly UK specific. We have a particular problem with under-resourcing and under-staffing in primary care, but actually I think we'll probably hear later on in this workshop from other countries that are also having problems with understaffing and huge amounts of workload because of higher demand, etc. We found techno-stress, and we're actually writing a theoretical paper around techno-stress, all the interruptions, information overload, technical problems. There's nothing more frustrating than a crash or a glitch and things can't work. And some staff were really stressed, so stressed that they resigned. And loss of confidence, lack of confidence, particularly in people in training grades, the trainees, not just the doctors. We interviewed a paramedic who'd completely lost confidence, etc. So these are some of the problems. We looked at the unmet training needs, and we've got quite a few papers on this, but just to kind of summarize, trainees, so new GP trainees who had not spent very long in general. Of course, their priorities for training were things like technical competencies. How do I work this technology? Triage, how do I do the triage? They were worried about medico-legal issues. If I don't bring a patient in, maybe I'm going to get sued. Maybe I'm going to get into trouble. And they were also concerned about their communication skills over the phone. So that was trainees, but and that's completely unsurprising. I think those of us who have supervised trainees. I was more interested actually in experienced GPs' unmet training needs. These might be people, like me, who've been in practice for 30 years. We're very confident seeing patients face to face in the traditional setup. What they talked about was making complex judgments. They said that there's some patients, it's very obvious that what's going on, whether they need to be brought in. With other patients, it's completely confusing. And then there's this huge gray zone in the middle where you really are making it a very, very complex judgment. Also taking account of the fact that if you give, for example, a face-to-face appointment to that patient, that means there's fewer for any other patient. They talked about working within the limits of technologies. They had to get to know what the technology could do and what it couldn't do, and factor that in their decision-making. They talked a lot about what I've called here coordinating multi-professional care in a distributed environment. And let me give you an example of that. The patient who has a urinary tract infection or has a suspected urinary tract infection might contact the practice remotely. A nurse might pick that request up and might then contact the patient, tell the patient to get someone to bring in a urine specimen. A healthcare assistant might then test that urine and then might put the results on the record. A GP might then look at the result of the dip and then decide that a specimen needs to be sent. Then later on, someone else will telephone the patient with the result, etc. And so what you get in the end with this very simple problem of a urinary tract infection is about 8 people having some kind of contact with that patient, and someone's got to join that all together to give the patient a kind of reasonably continuous, seamless illness experience. And senior GPs were very concerned about that. The other thing they were concerned about, I put supporting trainees, but some of them were very blunt and said, these trainees have not had enough hands-on experience. They've made a lot of telephone calls. We are not confident that those trainees are competent to do what is needed. We have published a paper in the British Journal of General Practice all about the training needs for staff. And we've also published as part of this paper, but also separately, and there is downloads. You can download them and do what you want with them. I've given you one example here. Competencies and capabilities for staff who are providing remote general practice services. So I've just given you an example here of clinical students and novice trainees. You can see the different categories here, but we hope that these competencies will feed into training curricula for undergraduates and postgraduates, because at the moment, those curricula tend to focus on the kind of technical side, but they don't focus on the kind of broader set of judgments that need to be made if you're going to be doing this kind of thing remotely. So I'm going to leave you to take a picture of the QR code if you'd like to. I'm just going to give you three out of many take-home messages for policymakers. We're still doing a lot of work with policymakers. We still want to have some dialogue to sharpen these messages, but here's three. Firstly is that technologies are never plug and play. They are always complex interventions in complex systems which involve people, and those people are not just individuals, they are teams. And so we get the sort of socio-technical system. And for academics among us, that the term socio-technical system is very familiar, but with some policymakers it's not. So that's an important take-home message. Secondly, that modern general practice involves distributed work. I've given you an example of that. We need to think of that distributed work rather than just individual tasks. And thirdly, the vulnerable patient. And I've said this earlier, but I think we really need to think very carefully about the multiply disadvantaged patient. I've put low health literacy, low digital literacy, low system literacy. This person is usually also poor. They've usually got few digital devices, and these people are slipping through the net in a big way sometimes. So I think there needs to be a lot more work around the vulnerable patient. So thank you for your attention.